Well, good morning, and thank you very much for coming to this kind of annual State of the Heart and Vascular Center. You know that we've kind of changed this to State of the System, and we'll come on and address this in a little moment. I was just telling Dr. This used to be easy. You know, we got a bunch of slides, came in, piece of cake, easy to jam it all into an hour. You've made my job very difficult when doing this, and this is because the exemplary programs that have been developed in all the different aspects of the Heart and Vascular Center. So I apologize up front if I don't give you your due worth in terms of due acknowledgement, but it's really a function of how amazing all our colleagues happen to be. So before I do that, of course, I've got the obligatory announcements. We're broadcasting via live stream and YouTube. We're not really going to have any questions, so the microphones don't really matter that much. This recording will be available up on our YouTube channel. Our first conference of the new year is going to be Re-Evolution. That's put together by, it's a minimally invasive cardiac surgery program put together by Dr. Ramchandani on January 25th and 26th. So with that, let me go ahead and address the system. Our system has evolved, okay? We've all lived through this. I've got many people who have been here. Dr. Reisner really was the first medical director for the Heart and Vascular Center. And for many years there was a discussion about where did the DeBakey Heart and Vascular Center reside? And for many years it resided here. What has happened, and many of us had the opportunity to listen to Mark Boom in his director's address, and the emphasis was all on the system. Now, what does that mean? And so, system means that a patient who comes into any Methodist hospital should expect to get the same high level of care. Clearly, there's differences in terms of the services which we offer. To do this, we didn't really want to roll the Heart and Vascular Center name out with able to control the brand to some extent. We all have open staff hospitals. You don't have to be employed in order to work here. That's part of our strength. By creating membership criteria, what we wanted to do is be able to control that brand, set criteria for quality, set goals for participation in this. And I think Emily Cowell, I always get that wrong, Emily Cowell was the one who really, this was a big job because I had to go through all the MECs of all the different hospitals. It really took 3-4 years in order to be able to do that. But that's why we keep talking about membership criteria, because it allows us basically to set standards, and we'll show you some of those as we move forward. And so although Dr. Boom was talking about one Methodist, we're really talking about one Methodist DeBakey Heart and Vascular Center. There really shouldn't be huge disparities. People, when they come into a Methodist hospital, don't understand the nuances of employment. It should be irrelevant. We really should be trying to raise the bar for the entire organization, and that's what we're going to do. How does systemness affect research? Well, you'll see there are now examples of if we can compete in clinical trials across the system by pulling in and recruiting from our hospitals, that kind of emphasizes that we've got to have the right research infrastructure and the right people basically who are going to take responsibility for these studies, then this is one of the advantages really of being part of the Methodist DeBakey Heart and Vascular Center. That has now been established. It's not generic across the system yet, but we'll show you a couple examples of trial where that is happening. We want to continue on the forefront. We are known for the quality of our education programs. And I'd say that the YouTube channel, will come back and talk to that, is seen by every trainee in the United States. And I think it's important that we continue to grow that and to build that. And we have one mission, and we'll talk about the mission. The mission should be the same regardless of whether you're in private practice or whether you're in academia. So the vision and the strategies. Basically, the vision is that DeBakey Heart and Vascular Center aspires to be a nationally recognized leader in the delivery of quality cardiovascular care with a commitment to research, teaching, and innovation. And I'm not going to go through all of these different components underneath. There's a lot of text on these slides. I'm just going to touch, on the bullet points. Obviously, we have to build and develop and maintain distinctive clinical programs. That's how we differentiate ourselves from our competitors. And take note, we're in a very competitive environment. We also want to be a leader in cardiovascular-based value care. Now, there's a number of different ways we can look at that, but one of them is in purchasing. Everyone here knows there's a huge amount of money that is wasted here on a daily basis. Very difficult to know when you ask for a guide wire or catheter how much it costs. I will say, hey, I go to Kroger's. I don't expect to walk up with a loaf of bread and get told it's $50 because I can check that out up front and it can show me. And so One of the things that we really like to do is have a little bit more transparency as regards to what the costs are, and to get you, the physicians, and we've built a value-based care committee who are going to look at this. How do we consolidate purchasing? And to try and help with that, what has been negotiated basically is a system basically of feeding back some of that savings back into the organization. It won't go in anybody's pocket. It will go basically to, if 30% of the savings comes from downtown, it'll come here. 10% comes from Sugar Land, it'll go there. Their leadership will define what it can be utilized within a broad framework of directions. Research and education are the main ways that we want that to be utilized. So we're trying to incentivize people across the system for participating in this. It cannot be Dr. Ray saved me this and therefore they're going to get a percentage of that. We're going to do this basically as a system. And we want to continue to grow the system network, and we have implemented a governance model. So again, part of this is really to say, who runs this organization? Again, it used to be Methodist DeBakey Heart and Vascular Center was down here, and we led it, we made the rules. But we've now broadened this out, so there's broad-based representation from administration, both centrally and in the periphery, and with representative physicians basically who are elected basically out in the periphery. And clearly this is going to turn over, and there'll be an opportunity for people to participate in that. So these are the people to blame. You know, the keys part in leadership are the ABCs, just like resuscitation, except in leadership, it's assess, blame, and criticize somebody so you get off the hook. But so this is a great group of people, you know, who help participate and setting the direction. And increasingly, there's a voice of the community and a voice of private practice basically being involved in this. We talk a little bit about leadership updates. This may not be visible to all of you, but Debbie Sukin was the system executive who was responsible for the Heart and Vascular Center, system-wide. So she was our sponsor, and that's a very important position when we're trying to get things done. Debbie, as you know, basically is going over to take the presidency over at Texas Children, a huge job, and I'm sure her father would be very proud of her because he was the previous president and was the dean at Baylor, the president of Baylor when I was first recruited down here. And that job is going to be taken over by Chris Siebenaller. Chris has been the CEO out at Sugar Land, so that leaves a vacancy. Now, who's going to fill that vacancy? So the guy who's going to fill that vacancy was announced yesterday, Michael. Michael Garcia is going to be the new CEO out at Sugar Land. That's kind of good news, bad news for us because he was the VP for the Heart and Vascular Center for many, many years. We got to work closely together. Then he became basically Senior Vice President in the hospital. And obviously, we're going to still have an opportunity and continue to work with him out at Sugar Land. So, Michael, congratulations. Very well deserved. We're very interested in who's going to replace you and who we're going to be working with, in addition basically to working with Kathy. So thank you all very much. These people are very important, you know, in order to be able to improve the mission and maintain the mission. If you look basically at the departments, of course we think of this basically as basically 4 departments participate in it. The Department of Cardiology, easily the biggest group here, led by Dr. Zogby. And again, he's the guy who's made my job very difficult because the explosion in recruitment into cardiology and in the research that's been done is truly remarkable. There's myself, and then on the anesthesia side, the chair is Dr. Stedman, but the person who's recently been appointed as the CV anesthesia leader is Gary Montero. So he's the guy who's going to help provide coverage at Sugar Land, out at West, and going to help up in the cath lab and in the operating room. Not the easiest job in the world, but I think you'll see Gary will make a huge difference. And then Dr. Cook, who just kind of walked through the door, basically has led the Department of Cardiovascular Sciences. And again, you'll see when I show you their accomplishments later. This is the family, okay? And we pride ourselves in the family getting along together. And sometimes basically when we have disputes, it happens inside the family, and then we go out basically and we lead with the title Methodist DeBakey Heart and Vascular Center. Underneath it are the folks basically who help us run this. Tammy Plum is the administrator for both cardiology and CV surgery. Tyler Kinney, CV anesthesia and critical care. And Emily Keo took over this job really, I don't know how long this has been going now, Emily, 3 years. And really that's a challenge in order to be able to do this, because hard as it is to organize things here, imagine basically multiply this times 7 and going up to 80 and dealing with all the committees and all the different personalities. So Emily put some miles in her car, but really has been transformational in helping to build this system. So that's kind of the background. And this is kind of where we're at. We're at 230 members of the Methodist DeBakey Heart and Vascular Center, and you can see really what the breakdown is here. We would like to see more of the private physicians participate in this, because this is the vehicle that we're going to compete with and we're going to move long term. Now, again, I'm not expecting you to look at all of these. We set goals each year of what we're trying to achieve in the next year. And these are some of the ones that we set in 2023. And I really think it's great to have the residents and fellows here, because they often are not involved in this strategy and understanding what we're trying to do. One of the things I've been trying to do, probably only for about 15 years, is to build this clinical practice repository. They've done a great job of this in transplant, by the way, but it's been nowhere in the Heart and Vascular Center. What do we mean by that? It means basically if you create a protocol, give us the protocol. Let us share the protocol. If they create a protocol out in Sugar Land, give us the protocol. Let's share the protocol. Let's take it to our various different committees and jointly agree system-wide that this is how we're going to practice. And I'll show you basically some examples of that. We've established the CV system service line goals, published the system cath lab, and again, I'm not going to go down through all of these different things. We've tried to grow this physician network, we've implemented this governance model, and as I say, we formalize this vendor alignment with shared savings. And you can see some of the benefits almost achieved, but we'll see hopefully within next year we can spend some of that money. For next year, we want to implement the system cardiology DOPs, okay? This is a huge amount of work, because I don't know how many pages are in the cardiology DOP, pretty large. The whole idea, again, is we're going to do it the same way at all of these different hospitals. It makes sense that we continue to do that. We've implemented system structural heart peer review. We would like to see all participating in there. There's been some barriers to this, particularly downtown, but we want to basically move that so that we all feel that we can get involved equally in doing these things. And we've talked about these clinical programs. We want to continue to enhance the physician network. We did an inventory really to look at all the services across the entire system. And this is, if you ever want to see this is just an example. Clearly, I'm not going to go through it. There are clearly going to be some distinctive services which are offered downtown, such as transplant, that are never going to be offered out in the periphery. But you can see the growth of MRI and CTAs and things like this as we kind of continue to build the system. So we need to continue to evolve the program. We will differentiate ourselves downtown by access to new technology and new innovation, which we'll touch about at the end. And again, not without its controversies, we built the system quality dashboard. We really would like to be able to see across the system how we're doing in the various different components of our organization. And each year, goals are set, not necessarily set by Dr. Zogby and I. We've kind of delivered some of these goals. These goals are stretch goals, whether it's in the Heart and Vascular Center downtown or elsewhere. Okay, the message really from Mark is, you are very, very good. But we're not in the top 10. I would kind of like to be in the top 10 before I die at some particular point in time. But we want to be in the top 10. I think everybody in this room probably thinks they're a top 10 organization, but we haven't got there. And so these goals are designed to push you. You probably get sick and tired of hearing about length of stay and readmissions, but that's the name of the game in terms of quality. Okay? We can build all these fancy programs, but the nuts and bolts of how we compete are mortality, length of stay, readmissions, and patient satisfaction. If you nail those, then a lot of this other things becomes irrelevant. And so, again, we often beat on this at service line, but these matrices are designed for us to help keep a focus on that and make sure that we're moving in the right direction. Let's get into the top 10. You clearly warned it. We're not there yet. So part of doing this is talked about these clinical practice repository. What my vision for this is, we would like to have the playbook for the Heart and Vascular Center. First of all, standardize this internally. By internal, I don't mean just here, I mean across the system, so that an inordinate amount of time is spent by people building protocols or building clinical pathways, and then we can't find them. They exist in somebody's drawer somewhere, somebody's computer somewhere, one of the other hospitals. We centralize that and share this, then that's a huge opportunity. The second thing I would really like to see happen is share it with the nation, okay? You got a lot of trainees, and what happens is that they get towards July, they're running around looking at basically, let me see Dr. Lumsden's protocol for doing an open aortic aneurysm. It's a way that we can influence. We want people to emulate what we're doing. And this is frankly a no-brainer, is to make this available with the appropriate disclosure so they come and see how an echo is done in Dr. Zogby's echo lab, or how an MRI is done, as put up by Deepan Shah. And so I think this is an opportunity to influence a reputational score for not a lot of extra work. It's not easy, but we're not really asking you to do anything except give us these protocols. Emily's going to be the point person on that. Send her a copy so we can centralize them. We have a system CV surgery service, or dinners. Let's look at it. Let's synthesize these. Let's learn best practices from our partners across the system and use this really to drive what we're doing. And these are just examples basically of what are being created and where this is actually going to exist. So that's kind of the goal. Recruitment has been very robust and continues really to increase. Again, can't go through all of these, but you can see roughly where we're recruiting into these various different system hospitals. And for the new folks that we're bringing on board, welcome. Some of them are not actually even here yet, like the 2 surgeons going out to West will arrive in the next 2 weeks. Make them welcome and tell them that we are trying to move this in a top 10 organization, and these are some of the expectations. We're also adding a new hospital, and Trent Fullen, of course, is going to be the CEO out at Cypress. Cypress is built. I didn't get a picture of it, the shell, but the shell is up, and they're going to start filling in the inside of it. And so this is another important opportunity for us. This is going to be a full-service hospital. It's going to have cardiology, cardiac surgery, vascular surgery. We think we know who the vascular surgeon is going to be going over there. We're in the process of recruiting a cardiac surgeon. It opens in 25. I know there's been multiple discussions about the cardiology practices that are going to be involved there. So the plan is to recruit the surgeons, for example, in advance of the hospital opening. Because there's office space which they can utilize, can operate basically out at Willowbrook. But we're going to try and get this up and running even before the hospital opens. You know this. So number 14 and we've bubbled along between 12 and 14 and 15, and the reputation score has been diminished in this. I talked to you really about what the matrices are going to be. It's really these quality matrices, because that's how we're going to move this up. Now, the message for this is a lot of this is, if you look at, for example, mortality. We had Vizient consultants who came in and they said, your mortality is really, really good. You're expected O to E. It's a ratio. We're not going to get that O down much more. Sure, we can always kind of work on it, make a little bit of improvement. The E, we're missing out on. We're not capturing the risk. We're not capturing the risk. So if you go to Mayo Clinic, they got like 150 nurses who basically canvass through the chart, finding out risk, heart failure, diabetes, end-stage renal disease, acute renal failure, that can influence that E. So obviously we're going to continue to work on both sides of it. More recently, for example, last year, our open heart mortality was deteriorated. And so we spent a lot of time looking at it. HDAI stands for Health Data Analytics Institute, and again, we're going to come back to big data. This is where big data can really help you. We spent a lot of time focusing on the hospital. For the first time ever, we got to see our mortality rate days 0 to 7, patients in the hospital. We're ranked 6th in the United States. Days 7 to 14, 20. By the time you got day 21 and 28, we were off the charts. We were less than 50. And so you're doing a great job in the hospital. We've been it's not that we're not focusing on the wrong thing. It's good to focus on that, but we weren't focusing on what happened after the patient is discharged. And that's where the next opportunity is. It's unfortunate, but if we looked at, again, for the first time we got to see mortality in SNFs, there was about a 10-fold difference in mortality in some of our SNFs. So that has been trimmed down to try and encourage people. We can't tell them where to go, but try and encourage them to go to the ones that have a good mortality. If you do a great job in the hospital and they die at day 29, that's Dr. Reardon's mortality. Unfortunate, but that's the way the game is going to be played. So we're going to have to be able to redesign these clinical pathways and push our care into the outpatient setting. Otherwise, we're not going to be able to improve this. So capturing the risk, that means documentation, and I think you're going to see this year a whole series of education programs in terms of what we need to be documenting, and then figuring out, which we're in the process of doing, how we extend our care for up to 30 days. Otherwise, we're not going to get that. But your good work has certainly been noticed in the community. One of the matrices that's used by our marketing department is preferred brand for heart and vascular care. And you can see that we are way ahead of our next competitor, Memorial Hermann. But, and the but that Dr. Zugby and I are always focused on is the trend. Okay, our trend needs to be sustained. We were doing great, basically, up until it started coming down a little bit. We're still way ahead. That's a big difference. Now, that doesn't mean you're going to be the busiest guys in the community, because not everybody can choose to come here. Because these are patients who would like to come here, but sometimes their insurance constraints or just their geography limits that. But what it does tell you is your brand is very, very strong. It's easily the strongest brand in this community, and we want to continue to do that. And that may not just be on mortality. That may be on how patients perceive, how we take care of them, what the processes are like through the hospital. We know we're always a little disappointed sometimes, and we do a great job, but basically the patient doesn't get discharged on time when they want to do it. And that can color how they think about us in the community. So looking at these processes is going to be extremely important. There's one of the things that was done because we systematized the Heart and Vascular Center. It used to be there was Sugarland marketing and West marketing and Baytown marketing. They were essentially competing against us. And they all basically would feature their surgeons. The entire metro area is divided up into, euphemistically called the MIC-map, that's in zip codes that we have direct access to. We have a really weird gerrymandered strip through the middle of Houston. But what was done, because we have a consolidated group of members, we now market system-wide and have the same branding message. Now, it certainly can be tailored towards the local community, but we're not basically going to have a completely different message going out in Sugarland from what we have elsewhere. It will be one message, one Methodist DeBakey Heart and Vascular Center, albeit if you call up in that zip code, you're going to get routed unless you're specifically asked to be sent somewhere else to that particular area. So that is very helpful. You can see the billboards have kind of reappeared. We've been talking about this for a long time, and it's really about trying to get the message out. One of the challenges here is that everything's good. It used to be that was Heart and Vascular Center, and the rest also runs. That is not the situation. That's the fundamental shift that's occurred here in the last 15 years. GI is ranked number 5 in the United States. They're above us, and several of the others are. And so all of our support services, and I really think that's one of the areas of trying to get this message out, is that you can come here for open heart surgery, but we're completely dependent upon the pulmonologists, the nephrologists, the intensivists who support our patients. And that's where this hospital, I think, is fundamentally different from what you're seeing in all of the other institutions. It's quality across the board, and this is now being recognized, in U.S. News and World Report. But we got to continue to push up there. And so we choose what we're going to target. AFib has been one that we've targeted. Venous disease, another one that we're going to be targeted. One of the things that we're being asked to do, and this may not be totally palatable for everybody here, but is to try and increase the number of commercially insured patients that we're bringing in. Okay, if you look at the Medicare and Methodist, is going up. If you look at commercially insured, it's coming down. That delta, I call it the play money. That's the play money that allows you to build the research institute, the research, the educational programs. If those cross, that money goes away. Okay, that's where the revenue is generated for the things that we want to do. And so you'll see some of this is going to be pivoted a little bit to identify in each of these different service lines where we can grow commercial insurance in terms of the number of patients that we're bringing in. And that's being asked basically of Tammy and all the different managers. Our national reputation, again, this is something that did not belong to marketing up until a couple of years ago. It went without a little bit of trepidation that this was done. But they're now working. When you go to ACC, you will see multiple social media posts, oftentimes featuring our folks, basically, who are the stars of the presentations. And that is also pushed out nationally. So they're working on our national reputation score. Unfortunately, that is not as important in U.S. News and World Report. It's still important, but it's down to 4% of the total of what we're looking at. So I have one slide here really on the Center for Critical Care. It's really a separate center now, but again, the influence of the Heart and Vascular Center across our entire organization is huge. Fazil Masood, rose to prominence. He was already prominent as the director of the CV ICU, increasingly involved in the CCU. and he's now in charge of critical care system-wide. Their matrices are remarkable. If you look at the outcomes for critical care in general across the system, they're ranking number 1 and number 2 in the United States. And a lot of that is because of Dr. Masood and the team of people who he's assembled around him. So thank you, Faisal, really for what you do in keeping not an easy part of the organization working. We often look at systems CV image and volume because this is almost like a reflection of the health of the organization. You know, I doubt there's a single patient that comes in for any of you here who's not going to run through some sort of cardiovascular imaging. And so it's an early flag if we're losing volume, and it's a really good thing when you see robust increases in the CV imaging volumes. And you can see they're essentially all going up system-wide. Massive numbers of studies that are being done. And I'm sure Dr. Nasser has got his eye on this in terms of how you pull that data out of here, because it's truly one of the flagship parts we see of what's being done here. Again, when I'm telling people about the Heart and Vascular Center, I say what differentiates us is control of the imaging. Okay, that's a vision that came from Dr. Zogby and Dr. Quinones many years ago and continues to be a hallmark of what we're doing today. The difference in trying to, for example, for me, talking about dynamic CT scans, being able to go talk to a clinician who works with us, who will help develop those protocols, is like night and day in terms of the ability to push the envelope in imaging. And so, again, huge core lab research group. Now, finally, I think we confirmed this, Kathy, is that we're finally going to get what's new that's coming down basically in imaging. And one of this is the Siemens Neotom Alpha CT scan. Okay, when this was, Dr. Zogby and I basically have seen this several times, and when this was approved by the FDA, said this is the biggest breakthrough in CT imaging since the development of the spiral CT scan. Less radiation, higher spatial resolution, less artifact. You can see inside your stents now. Again, there's blooming artifact. You can't see inside stents. You can't see through calcification. It should go away, okay? They've got one over at MD Anderson. We're going to get one this year, and it's going to be over in the outpatient center. And I think this is going to be yet another opportunity for research and development. I can't go through all of these things, huge publications. Some of these you'll see when I list the other centers. They overlap with one another because CV imaging is such an important part, basically, of almost everything that we do. Imaging leads to the diagnosis. Who controls the imaging leads to the diagnosis, leads to control of that patient, and then the long-term follow-up. And so, very difficult to capture the true value of having this patient inside this organization, but it's pretty significant as you move forward. One of the new additions, and so many years ago, there was a big discussion. We had no prevention and wellness program. And we're a budget-driven organization, so it's our strength, sometimes our challenges. And it was all, wow, man, we're going to lose money. We're going to lose our shirt on this. And so it was the tenacity of Dr. Zogby and then the ability to recruit some superstars basically into this to build this preventative, I don't want to call it cardiology clinic, I want to call it cardiovascular clinic. And I think for the vascular surgeons here, the vascular patients have the highest burden of atherosclerosis that exists on the planet. We need to engage this group a lot more than we are currently. And so this has led to, you can see the massive expansion which has taken place in this. You can see the publications really that are coming out of it, the collaborations that have been created, and I really can't thank you enough, Karam, for your leadership. And we'll come back and talk about what the big data focus that he has is going to affect. Once again, one of the problems in the Heart and Vascular Center, problem, but it's a good thing. We're the ones who usually push the envelope. Then we either get killed or you get moved up. And so, we've done this with all our administrators. We think we run the DeBakey Heart and Vascular Center advanced training in hospital administration. And so Debbie Sukin came through the Heart and Vascular Center. Mark Boom was the VP for the Heart and Vascular Center. Roberta Schwartz, David Bernard. And now we're glad to see the next graduate, of course, is going to be Michael. He's going to become a CEO in the system. So you're welcome, Mark. We'll just keep training folks for you. But one of the challenges is you reach prominence in the organization and you get tapped on to do something else. So that's really good. And Karam, you're going to talk a little bit more about it later. It's going to be tapped to head up a major program that's coming out of the Academic Institute. Can't go through all of this. We really weren't superstars in terms of NIH funding. so about 4 or 5 years ago, and that's been really one of the foci, particularly in cardiology, and you can see just exactly, what that has meant. We in the CV surgery department need to do a better job in doing this too. Obviously, we've got our first clinician scientist in Tricia Roy, and the opportunity is to collaborate and work basically with the cardiologist. Pivoting to structural heart, again, one of the huge success stories here over the past 7 to 10 years. I always like to tell why these pivotal clinical trials are so important. The first percutaneous valve was from Edwards. We had a group meeting with Edwards, which we invited everybody. That was a very bad strategic decision on my behalf. Did not go so well. And we didn't get involved in that trial. No TAVR program, no valve programs is the bottom line. Then basically we slimmed down the pitch with the right people making the pitch, and the people who led that were Dr. Reardon, Dr. Klein, and Dr. Little. And we got involved in the Medtronic trial. There was a lot of pushback internally. Okay, that device costs, at that time, $35,000. That wipes out the contribution margin in the hospital. And so this is why understanding the downstream effect of this, these patients all get imaged. Some of them are going to end up getting surgical valves. But you got to have these unique programs to differentiate us up front. At that time, that core valve was the single most lucrative trial ever run in Methodist Hospital, because we generate money for the research institute and the academic institute. COVID came along, changed that. They took over. But so it generates money for the academic institute. Our challenge is that's in this pot, but you're losing money on the hospital pot. Then what happened is that they did such a good job that people like Mike got invited to be the national leaders on the subsequent trials, and that led to half a dozen New England Journal publications. Now you talk about national reputation, that is national reputation. But it's very difficult to put a dollar figure on that. Then the device was approved. Well, guess where the training's going to be done? It's going to be done at Mighty. Medtronic were bringing 60, 70 cardiologists and surgeons down here on their nickel. We weren't paying for it. In our auditorium, watching our physicians and working in Mighty, and it generates revenue for Mighty. That's another bucket of money. And so understanding the continuity and the value of this is not easy for us to put together. And it's one of the challenges, I think, that going forward. But the valve program, in terms of revenue that's been generated in research, has really been the superstars really over the past few years. In fact, they've kept us going. And I think Mike basically presented the Evolute low-risk trial. Got huge press really associated with that. And so you lead these trials, you get the data, you're on the podium, and then basically you're the principal author or the senior author in the publication that comes down the line. And so this is an education process because, as I say, we're a budget-driven organization, makes us very strong. We're a budget-driven organization. Why would I give up something to you if you make $50,000 if I'll lose $10,000? That's one of the things that we struggle in trying to understand total value for the organization. And we continue to expect to see these trials as they continue to grow. Obviously, it's moving up into pulmonary valve, tricuspid valve, mitral valve. Nothing sacred really from the endovascular encroachment. And we're very well set up both in the imaging we've got in the cath lab and the imaging down in the hybrid rooms to be able to capitalize on this. And that group has a tremendous reputation. So these are just a few of the milestones that really came out from this. I got to take my hat off to Steve Little because we have opened up numerous, almost all the hospitals, not quite all, valve programs. Again, a little controversial. They're going to take away from us, and that's going to happen. But as we see the rise in the community, it's much more important that we're involved, helping to start these up. Mike would go out basically and participate in those cases, make sure there's quality, and I tell you, there've been no hiccups in terms of starting up these system valve programs. And if you as the leaders of the valve programs see the system as part of you, then that's a completely different way of looking at it in terms of our ability to recruit into these trials. Trials, we've got to compete for. You have to recruit. If we don't recruit, it costs us money, and we end up getting a bad reputation nationally. So the ability to expand our recruitment pool means you can probably recruit faster. That makes us look very good, and it also lets us participate in numerous other trials going forward. So let's pivot to the EP group. Again, yeah, an example to all of us really in how to do this. So they have a very active basic science lab under Dr. Altamirano, and you can see the things they're working on. The translational research, again, I mention this every year, that with Dr. Valderrabano managed to get a multi-center NIH-funded pivotal or clinical trial looking at vena marshal infusion. I can't even imagine how much work that is. And that's not without its challenges in running a multi-center trial, but he did it. And then basically you can see that the clinical research has moved out basically into the community. We've got cardiologists who are community-based, who are using Mighty, who have NIH-funded studies. And I think that's, again, an example of how you start bringing up research. It's not like you come down here and do research. What are the opportunities to be based out in the community and leverage the facilities that we have? We have the best facility in the planet. And sometimes it's good to bring on other people and walk them through and go, there you go, we've never seen anything like it. So the platform that we get to work out of on a daily basis and research and education, basic and clinical care, is second to none. And again, highlighted in red is this is what's important to the Research Institute. Okay, it's great to bring in money and philanthropy and things like that, but you're judged nationally based upon federal grants that are brought in. And if you get a grant, usually comes with indirects, sometimes over 50%, which is money that goes into the organization to help support it. And so I take my hat off to really the EP group. They're incredibly busy clinicians. They're incredibly good clinicians, and they're really setting the standard in terms of clinical trials that they're actually running. And so I think they're easily the premier academic group basically inside the city in terms of doing procedures and education. And you can see their volumes continue to increase. All right, so let me now pivot to the adult congenital heart program. Again, a program that didn't exist 10 years ago. Huey Lynn, of course, was the pivotal person that we kind of brought on board. And then basically Valeria basically is here. I think Valeria also runs the grand rounds for us. Big job. And you can see really the growth that has occurred. We took a dip in terms of surgery when we lost Dr. McGilvery. That's a real problem for us. Dr. McGilvery had multiple hats here, and he moved up to become the chair basically up in DC. He's now the president of the STS. In fact, he gives his presidential address later this month, and several of us are going to go down there to hear it. In addition to this, you can also see how the adult congenital heart program is starting to feed the transplant program. These are amongst the most difficult procedures that are done. And the lack of an adult congenital surgeon for a period of time basically really held us back in terms of moving this forward. So we'll come back and talk about transplant. So ACHD is, again, they've taken an approach of trying to educate, move clinics out really around the community, pushing this out basically in both Spanish and in English. And this is a lot of unreimbursed work to try and grow these programs. And again, it's one of those things that we always have a challenge. We're wedded to this RVU model, but man, we all know that there's a lot of work that gets done here that has no RVUs but are equally important to growing these programs. And so we need to be able to look at these programs as a whole. And these are things that we struggle with as an organization, because the entire contribution of the adult congenital heart program to what we're doing is first of all, it's distinctive, and secondly, if you look at the transplants, we're doing as many as anybody else in the United States. And they've worked very hard by extending this out into Clear Lake, and this continues to grow. I got to talk to Dr. Quarty, and so again, Dr. Quarty was recruited to head up the surgical part of the adult congenital heart program. He wouldn't be here without Dr. Duarte basically identifying him and saying, you got to hire this guy. Hire who? An Italian guy? Can he operate? And so she did the introduction. And it was very interesting because it's almost a landmark recruit. We've really not been in the business of trying to go to people who are not boarded in the US and recruit them in here. That we got to thank the medical executive committee, the leadership, and everybody basically for changing the rules to some extent, because we had to make the argument that he was a talent that we would have a lot of trouble recruiting inside the United States. Now, I know I'm going to make him cringe a little bit here, but I'm going to, not only is this guy, Turn it up for me. Should be going. Oh, if this doesn't play, you're gonna have to get up and sing. All right, Tyree's coming. I'm doing my part, I swear. All right, so if it doesn't happen, he had a big decision to make, part of his career, and that was so he was a professional Italian tenor. Doesn't have the body habitus for the tenors that I know that, but how could this little body generate that voice is just truly amazing to me. So we want to make money off his surgical talent. We're more than willing to farm him out, you know, for an appearance fee, but that money comes back to the Department of Cardiovascular Surgery. So Andrea, we're delighted to see you, and we look forward to hearing you. So the transplant program, the Doctor General program, continues to grow. We expect to see it continue to grow. They are a very cohesive team, all working together. Now, the bane of my existence for the past year has been Dr. Martin banging on me about how we're going to get surgeons in here to transplant program. Focused and tenacious would be the two words that I would use. It's like I started blocking around my phone. I can't deal with this. I'm working on it. I'm trying. And so, you know, obviously we lost Dr. McGilvray. We were essentially down to 2 transplant surgeons, and I think huge kudos to Eddie Suarez, basically, and Phil Chubb. Phil's not here anymore, he's in Sacramento, but I sent him a message the other day, told him we ended up with 61 heart transplants this year. We thought 64 heart transplants, okay. And so, you know, that's way ahead of what we did last year. We did this for half the year with 2 surgeons. They were getting killed. And so now we've added to that, we've talked basically about Dr. Quarte. Dr. Kay is in here somewhere, came over from Memorial Hermann. He's going to head up the mechanical circuitry part of this program. And Atticus is the first of our finishing cardiothoracic fellows that we've actually recruited. So we're back up there. Our lung transplant volume is up. Our heart transplant volume is up. Our VAD volume is up. And that's amazing. That's truly amazing. And so you can see the VAD program across the country went down largely because of other devices that came on, but we actually came back up and did another 11. I know that Dr. Martin's one of our passions is around the VAD. So thank you for what you did this year. Not only did these volumes all go up, if you look at acuity, they have the highest acuity in the medical center and the best outcomes in the medical center. So kudos to, I would not do this job for all tea in China because it's night work and thankless work, and they continue to innovate, and Neil basically is part of this program, supported the LVAD program, developed this plug that can be used to fix the hole in the heart when you take these LVADs out, and he won this Innovation, Safety, and Quality Award. But I do think we also need to thank the physicians, some of them who are still working at Texas Heart, but increasingly the heart failure program. We know these are superb clinicians. I think I just saw Barry in the back somewhere, but about 15-20% of these referrals are basically coming out from this group of physicians too. So thank you. This is not just, you know, the PO group, they shouldered the load of it, but thank you for working together with our group, and we look forward to seeing this, continue. And there's just, again, I'm not going to go through all of these things, innovative clinical trials that can be generated. When you have this kind of volume of patients, there's a number of different trials really which can be featured, all of which we're participating. I don't even want to try and pretend that I know what the LVAD Infection Consortium, not without its problems, but these drive lines kind of coming out through the skin. And it's great to see the ID community here basically participating in this. And the transplant and research group, you know, again, part of the family. And so very proud basically of the fact that some of the cardiologists continue to run a basic research lab. And that's really important as we recruit people to be able to say that where we want to, there are still opportunities to be involved basically in basic research. Distinctive clinical programs across the system. Thomas Lowe was one of our ex-fellows. He's built this amazing DVT-PE program. He presented recently with a business plan for broadening out the venous application really across the system. Younger patients, commercially insured patients. So these are the kind of things that we're really interested in trying to grow and to support basically as we move forward. Tricia Roy basically have talked about imaging basically as being incredibly important basically to these different groups, and a lot of this is done basically in conjunction with our imaging cardiologists. The Heart and Vascular Center Research Department. When John Cook came here, he really brought this concept of making these research affinity groups. And so this is not cardiology, this is not surgery, this is focus, an area of clinical focus. And by and large, this has actually been very successful. The deal with the academic institute is that the research operation, the Heart and Vascular Center is one group. We may subset it, and each of these groups basically has a leader who has a certain amount of influence over the trials that they're going to take on and what they're going to do going forward. Generally speaking, this in a year may be a little bit different. This has been a challenging year. This generates about $1 million of profit per year. This year, as I say, not quite. And so we've generally done a good job in bringing these patients in. And so one of the challenges going forward is that you got to bring in the trials that we're going to recruit to. We should not be taking on trials that we don't recruit. We lose money. Startup costs are all there. And so each of the different directors of this, I think, is going to be asked to make sure that those trials essentially stay in budget as we move forward. But by and large, you can see hugely successful in terms of grants that are being brought in, incremental revenue from industry being brought in, and publications that are being created. I started off with individual slides for each of these. It's impossible to go through the length and breadth of the people who are working in basic science here. I think one of the things that we need to do going forward is continue to make sure that we work together, okay? The opportunities are in collaboration, and so I think that we need to do a little bit better job, and that comes down to Dr. Cook, Dr. Zogby, and myself, and making sure that we figure out basically what the expertise is that's available, how we can line up the clinicians with this, and continue basically to push this forward. Translational research is the name of the game here, and this is an area where we need to focus on. There are 3 different centers that have been created up: a center for the bioinformatics and computational biology, RNA therapeutics, and John Cook basically is the center essentially of all of these. One of the challenges that we had this year was around our postdoc program. We have a huge number of people come in, 26 to 30 of them. And, let's put it this way. We had people who were working out of the scope of practice, people who were getting consents who should not have been getting consents. And so this has now all basically been centralized. Thank you for the group basically who've taken this on. And so the reason there's a process as we onboard these patients, it sometimes takes a couple of weeks, is they got to know what the rules of the game are here. And so bear with us as each of your different PIs basically is working with these folks. But we were not in compliance in the way that we should have been. I'm not going to end time to go into all of this, but we got this Academic Office of Clinical Trial. We have funding internally, not in the Heart Center, and the RI, that can take things all the way from concept all the way through to phase 1. And so very few organizations have that, but this is basically how we can do this. So as I say, we've also started broadening out the clinical trials into the community and starting to get folks in the community basically involved in this. As I start closing this out, I want to go back to 2 of the big initiatives that are occurring here. One is around big data. And as I said, Dr. Nasser is front and center on this, tapped to lead this development with Rice. So this is a funded role with the Academic Institute and Rice. It leverages some of the things that drive you crazy, and those things are big data. So let me try and give you an analogy here, okay? How many of you have got Teslas? You've got a Tesla. I'm stunned. Okay. I'm totally shocked. I don't even know what to say. Okay. So this is what a Tesla sees driving down the road. Okay. That's what you see. That's what it's doing. Okay. It's generating huge amounts of data. Is it raining? A score. Are there puddles in the road? A score. The light? A score. So now think about taking that Tesla model, which obviously has been pretty successful, and start moving this into our operating rooms and the cath labs. That'll going to be really interesting. We're tracking this as using computer vision to try and improve efficiency and identify problems. For those of you who have not been in the monitoring center across in Scurlock, you really need to go over there. It's a very, very impressive place. And so in the bottom is the virtual ICU monitoring station. This is all data that is being pulled out of here. Now, I mentioned this last year, we haven't really done it yet. We have to go from passive resistance, we don't really want to be bothered with this stuff, to active participation. This is gold, okay? This is gold for research productivity. And I would say to each of the different chiefs of these different divisions, figure out how you get access to this. We can help you and figure out how you leverage. There's not going to be a whole lot of extra work because this data is being accumulated. And if you look at this BioButton thing that's now you start seeing patients walking around, this is remote monitoring, and ultimately you'll be able to send the patient home with this. And so this has been done. It's been driven out of the Innovation Center here. You got to take your hat off to Roberta and having this vision and driving it through whether we liked it or not. I mean, because often that's the right thing to do. And this is basically the opportunity to go forward. So we're going to come back to that. Oh, need to shut down Roberta. That's easier said than done. If I can get a BioButton for that, that would be great. And I guarantee you she's going to know I said this before I walk out of this room. So as regards finishing off with education, massive growth. This is the cardiology fellowship. And the surgery side, we're now up to a full complement. We have a CT program. The program directors who need a lot of credit, Steve Little, Ross Rowe, and Eric Peden, run these programs. We basically go down to like number 2 and 3 in these matches. Maybe a little more in cardiology because they take a lot more than 2 or 3. But we are choosing the best and the brightest, and that's what's going to transform this organization and take it up into the number 10. We're starting to recruit new people. So again, other new program is around, one of the things that we've just started is this robotic vascular surgery program that Charo Bavaria really has taken on. This is something that vascular surgery has kind of missed out on. And so he took the challenge of going back. This is removal of an inferior vena cava filter. You try to move it endovascularly if you can. Some of them you can't get out. And I can tell you that the visualization, if you look at the thoracic surgery program here, 90% of their operations are done with this robot now. This is a $2.5 million robot, so not cheap to get involved in this. So we see robotics as being an incredible, and these robots are generating data, okay? Every time you move one of these arms, it's recording those arm movements. So you can tell about efficiency. You can tell about positioning. And so this is a program that we are on the leading edge of. We're going to have this Vascular Robotics Summit because we want to chart the direction for how this is going to evolve across the country here in March. We're using Mighty to do that. We're using the fact that the Intuitive Surgical put one of these robots here because there's so much basic activity around it. The DeBakey Education team. So this is we'll come back to this, is that DeBakey Education has undergone a significant amount of change recently. Not all of it for the better, but we've kind of got the team back together again. And so Chris Ibarra, Chris, where are you? Put your hand up. Okay, so Chris, sitting in the back, is going to be point person. He's going to be supported by Stuart Core. Is Stuart here? Oh, call out Stuart, he's not here, he's in trouble. Okay. Jennifer works for Mighty, but everybody knows Jennifer. She's going to be the point person at Mighty for all things related to the Heart and Vascular Center. Lavon Carlson is the assistant. She's essentially who works with Q and running the journal. And in the video production type, we've still got the same team. All the guys basically that are standing in the back. Tyree, everybody knows. George and Obed. This is DeBakey Education. These are the people we need to get to if we need them. And so the journal, basically, under Lavon's leadership and Q, has been completely transformed. It's predominantly digital. There's still a few hard copies, but now we can publish case reports, we can publish images. We want to encourage our trainees to start pushing things into this. In the past, it was just basically reviews. Now it's a full-fledged journal, and you can see the number of site users as we've broadened that out. We gave up a little bit with DeBakey Education. Now there's things that we've gained. We now have 2 studios. There's one over in Scurlock, and there's the original one that we built. And there's a podcast studio up there. And part marketing is part of corporate. That means free, okay? And it doesn't cost you anything to access this stuff. That's very important. But if we don't use them, you're going to lose them. And so we want to keep these guys busy. They want to do purely cardiovascular stuff. Isn't that right, Tyree? And there are now medical illustrators we have access to and medical animators, and we can get you all the contact information. Chris can get you that basically if you need access to those people. These are core resources that are funded. Obviously, I'm going to blow through that. We restarted the boot camp this year. The boot camp, I guess it's one of you guys put that together. You want to go back and show a little bit of that video? Maybe. Nah, forget it. But we're back in person this year. So the 2 things that are kind of really our flagship for the entire enterprise are the YouTube channel and the boot camp. Boot camp basically was, a mass movement this year. A huge number of people basically are here and want to continue to grow that, although the funding for it can be a little challenging. We want to leverage the YouTube channel. The YouTube channel, we're going to emulate what you're looking at here. And this is a radiologist in Sinai who essentially uses the YouTube channel as the bank. This is where you put stuff, but you can't organize it very well. And now we've got a web designer who will build a parallel website. So if you want to talk about open aortic stuff, we can put, here's the bank, here's the organization, and the links to the bank. And so we're trying to do this with open aortic. But again, all the division chiefs, think about how we can leverage the things that you've already done, already up there, and make it basically into courses or ways to communicate this. Chris helped us with creating DeBakey Bites. This is a kind of new offering this year. We're going to take, he sits in the back, boils a 1-hour lecture here down into 5 minutes, so that if you can't stand listening to something like me for an hour, you can get the 5-minute salient points basically when you're in the car driving. Pumps and pipes basically is really probably the foremost innovative things that we've done this year. There's a huge event down at the ION, which is part of the Innovation District, which has been created. Again, the things that are going on in the city that make it very exciting is that there's going to be this innovation corridor built from here to downtown. It started with the ION. For those people who've been around Houston forever, everybody knows what the old Sears building was. That is not a place you used to go hang out unless you could run really fast. Rice bought all of that area. They've built, it's called Greentown Labs, which is focused basically on green projects, and the ION, which is Rice, trying to do exactly what we did in pumps and pipes, bring Houston industries together, and that's why we can essentially run it here. TMC3 is an area worth going to look at. It's the new Texas Medical Center creation. Not easy to walk from here, but you can get there, and we're going to have space over there. There's nothing but tower cranes building the new space, and that's all going to be about innovation. And this dovetails very well basically with the NMed program that's been created here. A lot of these things, we are indebted to our foundation. Really sorry to see Susan move on this year, because she and Jackie and Emily have been key to being able to raise money. A lot of people in here have chairs, and a lot of it couldn't have been done without the foundation basically supporting it. And the last big donation that we got, really, and Stuart is going to be the executive director and help put this thing together, is around the Book Out Institute idea. There's an announcement about that. We're going to roll Mighty in there. We're going to roll MIRIN, which stands for Methodist Institute for Robotics, Imaging, and Navigation. Again, robots will be guided by imaging. We want to be able to bring that stuff in there. And this is, we're going to be able to recruit funding for hiring a couple of engineers who are going to provide the underpinning basic science to the things that the clinicians want to do. And again, leveraging where the hospitals already spend a lot of money, can we spend some more money and leverage that into education and research? And so that's going to take place. So 2024 in focus, as I close, it's going to be the era of big data. That's Quran. Imaging robotics, Stuart Core. And there's a fundamental overlap between these two, and we already got that. You can't be totally biased for the Heart and Vascular Center when you're in leadership positions, but you can be a little bit biased. And so we need to think about where we're going to go with this, and because I think this is an opportunity that I don't know that anybody else has really got this. And so when you're on the cutting edge, you can publish early trials, bigger trials, and you can run with this. This is an academic opportunity for people to make their names by using big data to analyze our outcomes. Nobody has got access to HDAI. This thing allows us to predict. Our PAs are going to be trained in this next week to predict real time what the mortality is going to be, the prediction of length of stay and readmissions, and allow us to intervene prophylactically in these patients we've not had before. So the things to focus are, these are the big initiatives, but clinically, we got to focus still on the basics: morbidity, mortality, length of stay, readmissions. You're going to be help from that with HDAI, which we'll all be educated on as we move forward. We've been dealing with this for some time. I think it's very valid and can be extremely helpful. That's the data that allows us to benchmark against like Medicare patients and look at basically what our outcomes should be. The research from a standpoint, everybody continues to do their own thing, but we need to focus on enrollment. And we got to make sure that the PIs for each of these RAG groups, you're either going to kick out the trials, basically they're not making any money, or that we can't have competitive trials that are not going to enroll, and we're going to work on that basic and clinical research integration. From an education standpoint, I've kind of alluded to some of those, but I also think that we need to continue to leverage that YouTube channel. That can be done with a parallel website. But we need to grow the videos. Why? As we bring faculty on, I go, Dr. Quarty, you owe me 4 or 5 videos. You can sing on it if you like, that'd be fine. You know, Dr. E, you need some videos. We need the same thing out of cardiology and the structural heart group. I'm not even going to mention other names here, but you know, there's 4 or 5 videos that are out there that we should have had up by this time, because it's our vehicle for national reputation and national visibility. And we're way ahead of the pack, and we want to continue to do it. So thank you all for being here. Thank you all for, on behalf of Dr. Zogby, Dr. Cook, myself. Yeah, it's tremendous working with you. You can be challenging, but you're challenging in a good way, and we kind of like that. So appreciate all the administration's help and support of it. Again, the financial stability of this organization is the platform that lets us do all of these fancy things. I certainly don't take that for granted, and thank you very much indeed. Appreciate it.